Please stand by. We're about to begin. Good day and welcome to the New England Nursing Home Quality Care Collaborative Kickoff Webinar. Today's conference is being recorded. At this time, I would like to turn the conference over to Melissa Miranda. Please go ahead.
Thank you, Alicia. Good morning, everyone, and thank you for joining us today as we kick off the New England Nursing Home Quality Care Collaborative. My name is Melissa Miranda, and I will be moderating today's session. I am the regional lead for the New England Nursing Home Collaborative. And before we get started, I'm just going to quickly review a few housekeeping items. Just to let you know, this webinar will be recorded and the presentation will be available within a few business days. I'll provide you with the details on accessing both at the end of the session. Your phone lines will be on mute for the duration of the presentation, so that we ask that you please do not put your line on hold during the webinar. We will be using the chat function to receive and answer questions. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. I'm joined today by my colleagues, Alex Bronk and Pam Paxman, who will be monitoring and responding to the questions and comments in chat, and we will go through the questions and answer them formally at the end of the webinar. Finally, if you find the presentation is a little cut off, just please use the plus or minus icons at the top right of your presentation window to adjust it accordingly. During today's session, we will provide an overview of the overall education plan, detail care transitions from a nursing home viewpoint, talk about how to use data to help drive improvements, and introduce the actual learning process for this collaborative. We'll have plenty of time to answer your questions at the end. Specifically, our objectives today are to describe the work that will happen between April and November of 2015, to introduce the topics that are sure to impact care transitions in your facility, explain how to use the data to drive improvements, and prepare each of you so that you know exactly what to do to be part of this collaborative. Before we get started, though, our regional team wants to thank you. It's because of you that we have successfully recruited 512 nursing homes out of 943 throughout New England to be part of this regional collaborative. We'd also like to acknowledge our nursing home stakeholders, both at the state and regional level, as well as nursing home corporations, both at the state, the ones that are within one state and also our multi-state, multi-facility corporations. Truly, thank you all for your willingness to trust the New England QIN-QIO to deliver an innovative and collaborative learning and sharing. We look forward to the opportunity to work together to improve the lives of residents and your nursing home staff throughout New England. Winston Churchill once said, "He who fails to plan, plans to fail." I'd like to let you know that our faculty has been hard at work creating an education plan for this collaborative. The educational plan is actually a 5-year plan. The goal is to engage at least 75% of the nursing homes in New England over the course of 5 years. We are already at 54%. You'll notice that there are 5 learning series listed on the left of the screen. The timeline for each series is listed to the right. It is our hope that the nursing homes, all of you who have started the collaborative with us in Series 1, will remain through Series 5 because you want to. The QIN-QIO team is ready to provide your team with access to the best practices and education that can be shared with your staff through brief learning modules that include activities to make the learning relevant and fun. Each series is made up of sharing webinars, online learning modules, and at least one state-based in-person event. Throughout the collaborative, it's our hope that if we're doing a good job, you'll tell your friends to join us. And if we're not, we want you to tell us so that we can make it better. So today, we're officially kicking off Learning Series 1, which is entitled Transitions of Care. Series 1 is what we are focusing on between now and November of 2015. Here are the important dates relative to this series. Although you'll receive an email reminder prior to each event, You may want to mark it on your calendar now. To start off Series 1, let's talk more in detail about care transitions. To do that, I'm happy to introduce my colleague and collaborative faculty member, Cheryl. Cheryl is a member of the QIN-QIO Regional Care Transitions team, and as the Care Transitions lead, she oversees the coordination of care project in Massachusetts. Cheryl leads a multidisciplinary team that provides on-site technical assistance to individual home health agencies, hospitals, and nursing homes. She supports multiple community coalitions and works to further the program's vision of improved care for all residents, regardless of payer. Good morning, Cheryl.
Good morning, Melissa. Before Sheila, who you should see on your screen, I'd just like to say thank you to everyone participating today. I'm so excited to be here with all of you as you embark on this learning series. Today, I'll start by telling you about Sheila, whose picture you see. Sheila's family has given us permission to share her story, and I know that her story will help put care transitions in perspective for all of us. Sheila was 72 years old when she started her 90-day journey involving multiple transitions of care. She had Charcot-Marie-Tooth disease, which is an inherited neurological condition, and COPD. Sheila was a registered nurse and was married for 50 years. She had 4 sons and 2 granddaughters. Sheila's sister is a registered nurse, and she lived about 70 miles away. The rest of her family did not have any clinical background. What you see is a timeline of the 90-day journey for Sheila. This journey included 27 transitions of care. She had 6 skilled nursing facilities with 4 different nursing homes. She was transferred to the emergency department 3 times, and she had 3 discharges to community home health services. In all, Sheila had 10 providers coordinating her care. So let's think about Sheila as we go through this webinar today, because I think we have all known patients like her. I am willing to bet that this story has sparked a memory of one of your patients or a family member. The journey. What that means is that Sheila's journey is not really a unique one, and that is what we have to remember as we embark on our care transitions work. One way we know that Sheila's story is not unique is through the statistics around hospital readmissions. Let's look at this from a national perspective. Readmissions is an enormous issue that adversely affects the well-being of countless older Americans. Nearly 1 in 5 elders discharged from the hospital is readmitted to the hospital within 30 days. What does this mean? Approximately 2.6 million patients are impacted. This results in a cost to the Medicare system of approximately $17.4 billion, and yes, that is billion with a B. And here is one of the most critical factors in all of this. Many of these readmissions are thought to be related to poor transitions of care between care settings, and are therefore potentially preventable. This is the crux of why we're gathering on this webinar today. Some of you might ask why we focus so heavily on the transition of care when we are talking about reducing readmissions. It is really because of what happens during that transition becomes critically important for the patient. Your residents may be exposed to greater threats to their well-being during a transition of care. We also know that it can take months for a resident with dementia to recover from the impact of a transition in care. But most of all, we focus on transitions because we know it is the right thing to do first and foremost for our residents. It is also the right thing to do for our fellow care providers. There is a lot of work being done that focuses on reducing hospital readmissions and puts the lens on care transitions. Working on hospital readmissions represents a huge opportunity for potential savings to the Medicare program. The Hospital Readmissions Reduction Program, also known as Section 3025 of the Affordable Care Act, began October 1st, 2012. In this program, Hospitals are penalized for higher than expected readmissions within 30 days of discharge for patients with specific diagnoses. These diagnoses are CHF, pneumonia, myocardial infarction, and the newly added COPD and total hip and knee replacement. Hospitals can receive a penalty up to 3% of Medicare payments. Hospitals participating in alternative payment model demonstrations, such as a bundle payment or an ACO, can only achieve savings by reducing readmissions to their hospitals. To address these concerns, hospitals are partnering with nursing homes and other providers, often creating preferred provider networks, where they will work specifically with these providers on reducing readmissions rates. These are penalty and incentive programs that we have known about. On the next screen, we will have a polling question so that we can find out how many of you right now are working in facilities with one of these alternative payment models. So if you are viewing this in full screen, the polling question will appear over the PowerPoint for you to answer. If you are viewing this within the Cisco WebEx Event Center, with a bar on the right side, the polling question will appear to the right side of the chat screen. You will have 15 seconds to answer the question once we open the poll. Here's the question. Does your facility participate in any alternative payment models? Your answers are yes, a bundled payment program, yes, a preferred provider network for an ACO, yes, an ACO and bundled payment program, both, or no. And then lastly, I'm just not sure. So if Jennifer could open the poll, that should be on your screen, and you will have a few seconds to answer. Okay, I think the poll has closed, and I think it'll take a few seconds for us to see the results on the screen. Okay, so we have the majority of people are really actually in the no category. So we have, and then quite a few that didn't answer. So hopefully we're going to do several of these polls as we move through this program today, and I'm sure you're going to get better at being able to take them. It takes a little practice. But I'm happy to see that some of you are aware of what kind of alternative payment models that your facility is involved in, and this is something we need to think about as we move through this work. So what's happening next? I'm going to just take a minute to clear that poll. There we go. So what's happening next is reform. It's here and it's not going away. More reform. And as you can see from our little cartoon, healthcare reform can come in two ways. The carrot, which is an incentive, or the stick, which is a penalty. So coming soon, we are going to have the Skilled Nursing Facility Value-Based Payment Program. And that's going to be starting in October 2018. In this system, all skilled nursing facilities will have 2% of their payments withheld and put into an incentive pool. You will then be given the opportunity to receive funds distributed back to you from that pool based on your performance scores. So the highest ranking nursing homes will receive the highest return, and the lowest ranking will receive the lowest return. So you may ask, why are we talking about this now if it's not coming until 2018? And that's because your performance score will likely be based on 2016 measures. So the good news is that you're on this webinar and you want to improve and work on issues in your facility. So starting the work now will only help you as the system moves towards the pay for performance incentive model. So let's talk about why transitions present such a challenge. Multiple providers. Let's think about Sheila, who had 10 providers managing her care. We no longer have a system. We have your family doctor that follows you if you go to the hospital and then to the nursing home. We have hospitalists, and we have highly specialized providers. Incomplete or inadequate communication. Let me ask you, have you ever received a discharge summary that did not quite paint the picture of the new patient sitting in front of you? Have you ever had difficulty pulling together the information so that others will understand the true picture of the patient you are discharging? We need to improve the communication between care settings so that it is easier and provides all of the necessary information for the next care provider, and especially for the patients themselves to understand their medical condition and follow-up. Medication changes and challenges. We know that each transition of care usually results in a change in medication. Pollination becomes an issue as most of our patients are on 9 to 25 medications with complex regimens that patients find extremely difficult to follow. We also know that our patients' conditions are incredibly complex. We now have patients with multiple chronic conditions that require extensive clinical oversight, as well as patient activation around self-management. We also fail as a system to truly explore the end-of-life wishes for our patients. We really need to recognize that it is never too early to understand what our patients want for care as they approach their final years and months of life. Strategies for success. Let's review some proven strategies for success to improve care transitions. First, we know that care providers must improve patient education and self-management support for their patients. Patients must understand their conditions and be engaged in how to self-manage them. Second, teams must enhance the support and care during this time of transition. This is a critical time that requires attention from the team. Third, the provider must implement multidisciplinary teams. And more importantly, all members of the team must be informed, engaged, and invited into the process to ensure that the transition is both necessary and safe. Lastly, we must engage in a patient-centered process around end-of-life care planning. As we mentioned before, it is really never too early to start this process. And the more we understand about how our patients want their care, the more we can ensure care is delivered, support those goals. There are a couple of important points to make about the strategies we just reviewed. First, it's easy to say, we got this covered, we do all these things already. What I want you to walk away with is that you need to take this to the next step. This is really about a continuous improvement process. The second point I want to make about these strategies is that if there is one thing we do know about care transitions, it's that there is no one magic formula or solution to make it all better. It is a process of going step by step with all of these strategies and embarking on focused improvement in each of these areas. This learning series will help you focus your approach. It will walk your team through the practical interventions that all relate back to those 4 core strategies for success. It will also provide best practice sharing opportunities from across the New England region. If there is one thing we really want you to remember about care transitions, it's that it is a team sport. On the screen are 9 topics that this learning series will cover. We're going to pause for just a moment as we advance our slide. So we have 9 topics that we are going to cover in this webinar. And as you move through this learning series, We will provide both practical and evidence-based interventions in all areas, such as preventing adverse events, reducing healthcare-acquired conditions, and addressing areas of clinical risk. We will look at how end-of-life care and advanced care planning play such an important role in improving care transitions. We will explore specific tools such as Interact, and we will also incorporate strategies for discharges and building connections with other providers. These topic areas all tie back to those 4 core strategies for success that I reviewed a few moments ago. Patient education and activation, enhanced care at time of transition, multidisciplinary teamwork, and person-centered end-of-life care planning. I would also like to note that where available, we will also offer nursing facilities the opportunity to join cross-continuum community coalitions that are focused on ensuring safe transitions. This will vary across the region, and you can contact your state lead to learn more about that opportunity. Your state lead's name and contact information will be provided at the end of this webinar. Another aspect of this learning collaborative is that we really want you to help use data to drive your improvement process. This is the perfect time to start talking about data.
Great. Thank you so much, Cheryl, for providing a solid overview of care transitions for the nursing home setting. We really appreciate it. So now that you have a general sense of which topics we'll be covering in Series 1, next I'd like to introduce Blake Morvis, who will talk about the data. Blake is our Manager of Analytic Services, and he supports various projects here at Health Centric Advisors through data management, computer programming, and data analysis. As part of the Medicare QIN-QIO contract and as part of Rhode Island's Healthcare Quality Reporting Program, Blake provides quality of care feedback reports to all of Rhode Island's acute care hospitals and nursing homes. Good morning, Blake.
Thank you, Melissa. I'm Blake Morvis, Manager of Analytic Services at Health Centric Advisors. I'm happy to have this opportunity to talk to you today about using data and the reports we produce to help support the work at your facility. Embracing data can help drive decisions to make improvements. Remember that examining reports are just the first step. Use them to establish a culture of inquiry to help you dig deeper and understand your data. Always be aware of the limitations of the data you are examining. Collect your own data to monitor the effectiveness of your efforts and be sure to share your data. You should also share successes with staff and solicit their input on measures that need improvement. Also remember, we are here to help. If you're viewing this in full screen, the following question will appear over the PowerPoint for you to answer. If you are viewing this within the Cisco WebEx Event Center, with a bar on the right side, the polling question will appear in the right side under the chat section. You'll have 15 seconds to answer the question. Here's the question. Is your facility looking at data related to hospital readmissions?
Hey, Jen, can you open up the poll for us? Thank you.
Just give it a minute to get the results. Great, so it looks like a majority of you looking at readmission data. And I think you'll be interested in seeing the different ways that we examine readmission data. I have another polling question for you. Okay, so is your facility looking at performance data on the long and short stay quality measures? Awesome. So it looks like a lot of you are looking at your quality measures, and I think you'll be interested in seeing the in-depth report that we provide on your facility's performance on the quality measures. So now I'd like to talk to you about the reports that we provide to help support your work. First, I'll talk about the readmission reports that we produce for nursing facilities. Then we will walk through example readmission reports for hospitals and communities. After that, we will discuss the standard analytic report, a report that covers your facility's performance on quality measures. The first report that I'd like to talk to you about is the facility readmission report. This report looks at your facility's 30-day all-cause readmission rate. The data is based on Medicare fee-for-service claims data, and the report also provides your facility with state and regional benchmarks, demographics, and diagnosis information. Let's take a closer look at this report. For the nursing facility 30-day hospital readmission rate, we provide an 8-quarter trend of your facility's 30-day hospital readmission rate. The 30-day hospital readmission rate is based on the percentage of patients discharged from the hospital who are transferred to your facility and are readmitted back to any hospital within 30 days. On the chart, each blue column represents your facility's 30-day hospital readmission rate. You can compare your facility's performance to the statewide 30-day hospital readmission rate and a New England rate to see how your facility compares to your peer nursing facilities within the state and New England region. It is important to know that all of this data is based solely on Medicare fee-for-service claims and is not risk-adjusted. However, it is also important to recognize that CMS is penalizing hospitals for excess readmissions based solely on Medicare fee-for-service claims. On the second page of the readmission report, we provide two tables. The first table on the left is a list of index admission diagnosis categories, and the table on the right is a list of readmission diagnosis categories. Both tables are limited to the latest quarter of data and to just the residents that were readmitted. The table on the left, Index Admission Diagnosis Category, provides a count of what the diagnosis categories were when a resident entered your facility. The table to the right, Readmission Diagnosis Category, provides what the diagnosis categories were when a resident was readmitted to the hospital. Let's take a minute to talk about what the data is not, and what else you can do. The data used is not risk-adjusted and limited to only Medicare fee-for-service beneficiaries. However, hospitals are interested in this data as it currently relates to value-based payment, and this presents an opportunity for a nursing facility to present the value they provide within their community. Embracing and utilizing data can drive change to improve processes and resident outcomes, and while claims data has an inherent lag, it is great for trending and combining with facility-collected data. So that's the report that we provide to you, but I'd also like to share with you some of the other readmission reports we provide to hospitals and communities. Let's walk through the hospital 30-day readmission report. We thought it would be helpful to share this with you so that you can see what data the hospitals are looking at. The chart at the top left provides the hospital with a 30-day all-cause readmission rate by quarter. Below this chart are three charts on readmissions that are subset by specific diagnosis categories: AMI, heart failure, and pneumonia. On the second page of the report, we also provide readmission data on COPD, total hips and knees, and readmissions to the ED and observation. On the bottom right, we also provide a table that summarizes performance on each measure and how their facility ranks compared to other hospitals in the state. While not displayed here, we also provide hospitals information on index admission diagnosis categories, readmission diagnosis categories, and counts by diagnosis category on how many patients were readmitted to their facility versus another hospital facility. The last report relating to readmissions I would like to highlight is our community report. As part of the 11th Statement of Work, we are moving beyond the silos of our own four walls and building communities of providers who partner together to improve transitions of care for patients they share. In these communities, or coalitions, we provide reports that focus not on the facilities, but rather the patients. The reports include utilization data about the patients who live in the zip code catchment area. These reports include population-based measures on readmissions, admissions, ED and observation utilization, and mortality. By using the community report, coalitions can monitor the impact of their collective actions. Let's take a closer look at these reports. As you can see, at the top of this report are community data on all-cause readmissions and all-cause admissions. The three charts on the bottom cover ED visits, observation visits, and all-cause mortality. Coalitions can use this data to monitor trends that are occurring within their community and to help gauge community performance. State and regional rates are provided as a comparison for each measure. This is the second part of the community report, and like the hospital report, readmission data are examined within the community by specific diagnosis categories: AMI, heart failure, pneumonia, and COPD. Coalitions can examine performance on specific diagnosis categories to determine if any unfavorable or favorable trends on a specific diagnosis category are occurring within their community. Again, to help gauge performance, state and regional data are provided as a comparison. If you would like to learn more, please contact your state's nursing home lead to learn if the QIO is working with a community in your area. I would now like to talk to you about the Standard Analytic Report. Let's first talk about what is the Standard Analytic Report. Standard Analytic Report is a quarterly report that we produce that provides you with two different reports about your facility's performance on the quality measures. The first report is a two-page summary report on all of your long and short stay measures. The second report contains 8-quarter trending charts for all of the long and short stay measures. So what is the summary report? The summary report provides all of your long stay measures on one page and all of your short stay measures on the second page. Each page allows you to quickly gauge the performance of each measure versus the performance of other facilities within your state. All data used for the summary report comes from Nursing Home Compare. So why use the summary report? By using the summary report, you can assess which of your measures are performing within the top quartile which measures are performing in the bottom quartile, and of course, some will fall somewhere in between. Let's take a look at the example displayed. On the left, we can see that this facility has a percentage of residents with pressure ulcers of 1.3%. This result is represented by the diamond on the chart, and you can see that the diamond falls within the green shaded box, which is in the top quartile of all facilities in the state. On the right, we can see this facility is having trouble with the ADO measure. Their percentage is 33.6%, which is a result that is in the bottom quartile of all facilities in the state. Let's walk through how the summary report works. First, the facility's current performance is plotted as a diamond on the scale above. Using the high-risk pressure ulcers example, the diamond is plotted at 1.3%. Second, the range of the top quartile is added to the chart as a green shaded box. This is the range of scores that represent top performance within the state. This is where you want to be. Third, the range of the bottom quartile is added to the chart as a red shaded box. This is the range of scores that represent bottom performance within the state. This is where you do not want to be. The questions to ask when reviewing your summary report. Which measures are performing at the top? Be sure to recognize your success. Why are we performing at the top, and how do we stay there? Which measures are showing poor performance? How can you get your facility out of the red and into the green? The next part of the standard analytic report are the trending charts, which are provided for all long and short stay measures. Your facility is trended over 8 quarters, and comparisons to state and national data are provided. This is an example of a trend chart. The red line with diamonds represents your facility's performance with the associated measure. The light blue line with squares represents statewide performance, and the dark blue line with triangles represents national performance. We can see in the example displayed that this facility has made great improvements on the ADL measure. The trend charts like this are provided for all of the long and short stay measures. So why use the trending charts? Just we can view directional trends over time to assess the performance heading in the right or wrong direction. You can also look at how your facility is performing against state and national data. Additionally, you can also assess if any interventions you are applying are impacting measure performance. As part of our initial distribution of the standard analytic report, we are also providing you with your facility's composite score. The composite score is a measure that combines all of your long stay measures into one measure, so that in the end, you have one number that represents your facility's performance on all of the long stay measures. The composite score is a measure that CMS developed to evaluate QIO performance. In the interest of transparency, we wanted you to know how the QIO is being evaluated, and we have provided you with your facility's composite score, but please be aware that we do not plan to provide the composite score going forward. So let's take a minute to recap the reports we discussed. We provide readmission reports to nursing facilities, hospitals, and communities. Data is based on Medicare fee-for-service claims, and the reports are available to nursing facilities participating within a community care transition coalition. We also provide a standard analytic report that helps nursing home facilities evaluate their performance on the long and short stay measures. The data is based on Nursing Home Quality Initiative data, which is derived from NBS 3.0 data. And the reports are available to facilities participating in the New England Nursing Home Quality Care Collaborative. Both reports are produced quarterly. Please contact your nursing home state lead for more information. To end, I'd like to think of our reports as an appetizer. Exploring these data should whet your appetite and leave you ready to jump into your own data story. Our reports can highlight opportunities for improvement and can highlight your areas of success. And we are here to help. Remember to add a healthy dose of data to your diet. In moderation, it can have many benefits. Thank you for your time today, and I'd now like to hand the presentation back over to Melissa.
Great, thank you, Blake. So now you know that in Series 1 we're going to focus on care transitions, and you also just heard about ways in which you can track and monitor your data that will help you as you reach your improvement goals. Next, let me introduce you to Margie McLaughlin, who's our Consultant Director of Education. Margie has over 25 years of long-term experience, and today she'll describe the details about this learning series and describe the steps that you'll need to take to get underway. I'd also like to say today is her birthday, so happy birthday, Margie, and it's over to you.
Thank you, Melissa. Thank you for that lovely acknowledgement. The QIO World, as you know, is filled with lots of acronyms. It's a proverbial alphabet soup. And so the first acronym I'd like to share with you is on the next slide. It's called What's a LAN? Many of you have been part of them in the past, so you can advance that slide for me.
Picking up a little bit. Just wanted to let you know.
Thank you. So the LAN is actually a learning and action network. And what's exciting about our work is that all throughout New England, and even more importantly, all throughout the nation, nursing centers all around the country are engaged in a LAN. And so what is it? It's a learning and action network is basically a community of people who are connected through education, dissemination, and sharing of ideas and best practices. It's dynamic, and that's what makes it great. It's people taking the time to practice and try new things and then bring their story back to the group so that people can learn and understand better and better ways to do things. We, as a community, are a community of sharers. And so one of the things we like to always share with people is to share shamelessly. So it's not about stealing, it's about sharing. And what we know is that our learning and action networks work best when you come to our calls and share some of the insights that you have had as you begin to help to disseminate this work all throughout your organization. Beauty of this then is we're not doing it in isolation. All of New England will be spreading these practices and working hard to improve the lives of residents all throughout New England. It's pretty exciting. One of the things we always like to kind of point out is a real rhythm to what we're about to engage in, this education process. And so the first part is obviously to prepare, and we'll be giving you some tips on how to go about that process. And then to actually deploy. And so what that means is put the plan in motion. We use the third element is a thing we call pollinate, and I'll talk a little bit more about this, but pollinating is basically finding as many different ways as you possibly can to take the information and spread it all throughout your building. So many times we think about transitions as a nursing project, if you will. It's a nursing issue. It's a clinical care issue. And one of the things we want to really leave you with today is a really strong sense that transitions of care is a community, an entire nursing center's work. That includes families. That includes the residents themselves. That includes all of the folks, including the maintenance staff and the housekeeping staff. And throughout our education, we'll show you how you can engage some of those folks. The last of these in our rhythm is then to review your process and see how it's working for you. Are you getting the results that you hope? And that's really key to our story. So the LANs are happening all over the country. We're working throughout New England to bring this information and these education series to you. So on the next slide, you'll see what's pollination education. And pollination education started in Rhode Island. It was a way that we began to talk with nursing homes about thinking differently about the way education happened. Let me just give you a quick insight into that. So many times, and I'm sure you all have lived it, we bring and gather loads of folks into break rooms or little conference rooms, and usually around 2:30 or 3 o'clock, and we share lots of information with them, and we try to have that particular session as many times as we possibly can, with the night shift, with the day shift, with the PM shift. And so what we began to realize was it wasn't always as effective or as we would hope. And so as a result, what we discovered was that something that would be much more viable for folks would be a little thing called pollination education. The idea is the method for spreading information. There's very small learning modules with corresponding activities and engagement. And the challenge then becomes how far and wide can you actually spread the education. So to give you, for instance, when we take the very first element, which is the element that looks at introducing transitions of care, what our job will be is to get as many people as possible to hear that information, from the maintenance department all the way through activities, housekeeping, nursing, CNAs, everybody, families as well. And the idea is to make those, just take that one small little module or a couple of key elements from the information that we provide to them and spread it as far as you can. Pollination happens all throughout the organization, and so it really becomes a very interdisciplinary process. Everyone becomes involved and aware of the work that's being done, and it especially includes families and residents. So, in the next slide, talks a little bit about ways that we've seen people creatively pollinate all throughout previous work that we've done. How do we pollinate? We do it creatively. We've seen people put table tents in the break rooms that says, hey, don't forget we're doing transitions. Or people come up with great little taglines and ideas for helping people, campaigns, if you will, that help people to kind of keep their eye on the ball and focus. We've seen people make posters and create a bulletin board that exclusively is used to show how the process is going. We also have seen folks in the past use resident council meetings and family council meetings to talk about transitions of care and to educate families and residents. And as you know, that's going to be a big part of what we do in the upcoming months. We also have seen progress boards, and progress boards are handy because they help people to see how far the movement and the progress is being made. And so what we see is how many staff have, filled out the survey or watched the video or attempted the homework assignment, or what people discovered when they actually did the homework. So this is a great way to promote and help people to kind of stay engaged in the process of education. What pollination education ultimately does is it creates awareness and transparency and a whole lot of energy. And what we encourage you to do, I hope you have getting ideas as you're sitting here with us, and find ways to make it fun and really worthwhile for people to be part of it. If it's dull and boring, the ability to transfer knowledge to practice on the floor of a nursing home will be really limited. So as exciting as we can make it, that's what we are going to try to do, and we hope you'll do the same as well. As you can see, and Cheryl already has kind of mentioned these to you, these are the topics that you're going to hear about over the course of the next few months. Why we chose these are because they make such a huge impact on reducing rehospitalizations and improving transitions of care. But we also know, what we want to let you know is that we've lined up a great cast of experts. Lots and lots of folks who do great work in the world of transitions are part of these education modules. what we want you to know is that they're going to be delivered in an enormous number of different ways. And so in just a couple of minutes, we're going to check with you to see how you like things, how you prefer to have things delivered to you. On the next slide, what you'll see is that we have chosen these because they make such a difference in the lives of residents. And ultimately, when all is said and done, our work together is all about improving lives of residents. Not just individualizing care when it comes to advanced directives, but ensuring that all throughout this process that there's a very distinct and very direct way that we impact the lives of residents. One of the key features of this story is to really think about, for example, from the Jewish home. And the Jewish home had made an effort to look at their data, and as they were going through their process, they realized that something that they could be doing to improve the lives of residents and to limit the number of rehospitalizations that were taking place was to actually talk to people more directly about the types of care they wanted as they got sicker, and to really drill down with people around the advanced directives. There's a great study that tells this story, and I'll be sharing it with you during our education, in one of the education modules. But what's key to the story is that as a result of talking with families and residents about advanced directives, they were able to reduce rehospitalizations by 25%, which you can just see in its own right is a real coup. So that being said, that's the nature of some of the work that we'll be doing and some of the conversations that we'll be having. So as you look to our next slide, what our intended outcome is to save lives, ultimately, improve care by ensuring that our staff have a really great working knowledge of transitions and all of its and all of the many facets of transitions of care. We also want people to know what to do and when to do it. Everybody from, as we said, from the housekeeper all the way through the home nursing staff to activities and the maintenance folks. So everybody's got a job, and that's what this is all about. And then the last part is what we hope to really give people is a great sense of confidence that they're doing the right thing and that they know they're doing the right thing. As a community, what we're hoping is that we become really adept at transitions of care and make a huge difference in the lives of residents all around New England. So here's what we want to walk you through, a little bit about preparing for Series 1. But first I want to tell you that Series 1 is the first of 5. And I think you've heard this on a previous call, but the next series will be on antipsychotic drug reduction and dementia care. The third will be on quality measures. And then we've left a little space so that you folks can kind of weigh in on what might be the best things you'd like to hear about. This particular series, Series 1, goes from March 26th all the way down to November. It's going to give us a lot of time together to learn all of these different topics and get more familiar with them. What we want to share with you is right now how to begin to prepare. We consider the next month to be the preparation period. So during this time you won't see modules popping up and you don't have to try to get people doing education at the moment. What we just really want you to do is to begin to prepare your organization in the best way possible. So some of those things are things like who's going to be the champion of this project and who's the alternate. We want you to gather a small team, probably like 7 people or so, who will be the guardians or who will shepherd this particular learning series. And what that means is they're the folks who are going to help in a big way to help to pollinate. They're the ones who are going to kind of talk it up. They're going to have specific duties, and you want folks that you can really count on to be kind of a spark plug, those energy, enthusiasm people, and people who are really committed to transitions of care. During this time, we also want you to kind of take a check and see. We're noticing in the polls that there's a whole gang of you who aren't answering, and I'm thinking that just from wild guess, I'm thinking there's a lot of you who probably don't have computers or aren't able to access computers, and maybe are listening by phone. And so what we want to be sure is that your computers are in good shape, that you have sound on your computers, that you can get out on the internet. And if you're not that guy, then maybe what you can do is find somebody in your organization who can do that kind of computer assessment for us. What we're going to talk to you a little bit about and let you do on your own in this period, this 1 month period, is we're going to ask you to actually make a plan. So you have 9 learning modules that you'll be going through. And so what we want you to do is actually think about how you're going to do that over the course of the next 8 months. What we'd love for you to do is to actually put together a timeline, think about how you're going to disseminate some of those things, think about how you're going to promote it, think about how you're going to engage families. All of those things become really an important part of all this. So, like, quite literally, we're asking you to kind of make a plan for how you're going to go about over the next month, actually put together a little work plan that details how you're going to go about the process. What we also want you to think about is the QAPI assessment. It's one of the things CMS asks all the nursing homes to complete. It's quick and easy, and it just basically asks you to be able to take a look at some questions and just answer them as they relate to QAPI. We're going to have that set up on a Survey Monkey, so all you have to do is go in, read the question, click a button, and you'll be done with that. So, easy process. That's also during this preparation period. We ask you to complete that. And when you're all done with all of this preparing, we want you once again to go in and complete a Survey Monkey that asks you a few questions and helps us get to know you a little better, and also ensures that we know the best way to get education modules to you. So that's going to be key to our story. The way that we know that you've done the preparation and are ready to go is you filling out the second Survey Monkey. So that's kind of like the green button, that's the ready button that lets us know that you're ready and that we can send information to you. And we're probably going to need to have 400 people fill out Survey Monkey. So that'll be your challenge once you've completed all of these details. What I want you to know is that we've prepared a little booklet for you, and on page 11, it gives you a very specific checklist. And that checklist is kind of handy, and it will help you to get a really good sense of what you need to do during this preparation period. All the things I've mentioned, and it gives you just a little bit more information and background. So I think you'll have good luck once you see that. One other thing I want to just share with you about the training is that it comes in a number of different ways. Obviously, we have these training modules that we're going to be putting online. We also are going to make every effort for those of you who have difficulty or don't have computers that you can access. We'll be sure to send you those items in paper so that you can work with them and use them to educate staff and families and residents. But we also want you to know these conference calls are going to be a key part of it. More importantly, the real important part of these conference calls is your ability to share stories about what you are doing in your organization in order to succeed and to make this thing happen. So we'll just so enjoy hearing from you. Even if you're struggling, be sure to come and let us know, because there's probably a lot of other folks who are doing that as well. So our calls in these conference calls going forward are going to be a great opportunity for you to share what you're learning, and we'll be talking with you about some of that further. Some of our staff will be kind of tapping you on the shoulder and asking if you might share a story or two. So keep that in mind. The training modules, again, will be available in a number of different ways. And then what we call an action period is part of this work. The action period is the point between, if you will. So there's going to be some modules that are available to you, and then that's where the action takes place, along with kind of showing people that information, teaching them about Interact. We're going to give you assignments for your staff and for you so that you can actually begin the implementation of Interact in your organization. And so whether that's including transitions or thinking about healthcare-acquired infections or whatever that particular thing is, the action period will give you an opportunity to go and do. And the do is really all about having some fun activities that get staff really involved and help to further educate them in a really practical way. So that action period will be hopefully a big help to you. And then also the last piece is you'll be receiving periodic emails from us. So keep an eye out. If you have any good resources in addition to what you already received, you'll see those coming through the mail. So that kind of gives you the big picture of the training, kind of helps you to have a sense, I hope, of what to expect over the next 9 months, and more importantly, what to expect over the next month. So over the next month, it's your opportunity to kind of dig in there and set the program up in the best way that you can. We encourage you, any difficulties you're having, contact the state staff, and we'll be there to help you as much as possible. Well, we just want you to know how much we totally appreciate. We realize that you're working hard on our end, but we know ultimately all the delivery and all the hard work is really yours. And so we want to thank you so much for all that you're doing. And here's what I'm going to ask you to do. We wanted to, online, while we're here together, to actually do a little poll to get a sense of comfort with computers and access to computers and that sort of thing. And so I'm going to ask my team to bring up the next polling questions and get everybody ready. I actually have several polling questions for you. So here you go. Does your organization have computers that all staff can access and use when they need to? So go ahead and answer that if you would. What that means is kind of like if it's in the director of nursing office and nobody can go in the director's office, then that would be a no. So just give some thought to that, and if you could, just go ahead and fill out the poll, and as soon as we get the results, we'll show you that. This is partly for our benefit, but I think it'll give you comfort to know, like, other nursing homes' accessibility. There you go. So, so I'm looking at quite a few yeses, and our next question, I'm going to ask folks to bring it up. I'm noticing lots of no answers, 130 no answer at all, so I'm curious about that. I'm thinking maybe people don't have access. Let me ask you this. We're kind of gauging the skill level of staff. So for the most part, what's your staff's computer knowledge? Are they beginners? Are they intermediates? Are they experts? Overall, if you look at your whole staff, what's their skill level? Go ahead and kind of weigh in. I realize you might not know all throughout, how your CNAs and how the activity staff are able to do that, but just sort of the general sense of how you would rate overall the organization. And while they're waiting for that response, let's see what we get here. Oh, look at that. Looks like we have quite a lot of intermediates and a small amount of beginners. So we'll be able to get a little more information on that. That's a good one. All right, let's take a look at the next question. And thanks so much. You guys are doing great out there. And it's very helpful to us to have a sense of the responses here. How about some of this one's for CNAs. Do CNAs use computers for in-service education in your organization? go ahead and fill that out. We know that a lot of folks use it for fire safety and lots of other kind of mandatory type things. So we're just curious what CNA comfort is with computers, and do they use the computers for in-service education? And we'll get that one up in just a second. Things to think about. Take a look. Lots of no's. Okay, well that's good to us. And so let's take a look at the polling question 4. And it asks from the perspective of the staff person who will serve as the champion, so chances are somebody on this call, what's the preferred method that resources are made available? And so one is to please just send me paper, have the resources available so I can download them to use with my staff, or have them organized so that staff can just go online and learn on their own. So why don't you give us a sense with your comfort level? One of the things we wanted to remind people, and then it's written in the preparation booklet, is you should get a binder and start putting all this information into a binder and organizing that, because that'll be really helpful. As it turns out, you need paper. We can sure accommodate you. Yeah, look at you. I see that paper got mixed. I'm happy to report, and people are looking to just be able to download some of those. So sounds good. I think we can accommodate you there without any trouble. And so let me take a look at this next question. This one's a little more complicated because if you haven't had the experience, there's a thing called a learning management system. So some of you have gone to school recently, you might have tried something like Blackboard, or there's a whole bunch of different things out there. Learning management system is an online learning community where learners can take classes, they can track their progress, they can get certificates, they can talk to each other, they can complete classes and take quizzes. Have you ever used one? Go ahead and answer if you've used one yourself. So the class is taken there. Then the process that health-centered advisors for the whole New England region of using a learning management system so that you can track who's taking the education modules, provide certificates. It kind of automates the whole thing. So look at you. You are one-handed group of folks, 93 out of 248, and of those answering. What a great response rate. Thank you for that. So I think we'll continue to go ahead with our plans there to make things simple for you as we move through question 6. We want to check in with you. How's the training actually done in your setting? Is it a classroom? Is it a webinar? Is it an online training? Do you do it in groups on the unit? So as soon as we get that next question.
Polling question number 5 is actually has a couple of pieces. So it's, would this be a practical means of teaching and support for your organization?
Thank you. Go ahead. So would this be a practical means of teaching and support for your organization? Thanks, Melissa. Can you give us a yes or no with a learning management system being practical for you? Would that be a help? One of the big things we're trying to do is make sure that you don't have additional burden as you go through this process. So let's see what we got. Yeah, I'm seeing that people did like that. That's great. What else you got there, Melissa?
So the next question is, based still on the LMS, would you be interested in learning how to use it?
Okay, so would you be interested? I'll give you a minute to answer there. A couple seconds to go. We found that the learning management system is such a great way. That way you have a lot less to manage, and the system itself makes that easy and doable. We'll have a session to train you so you know how to do it. Well, let's see what we got as a response here. got it coming up in just a second. There you go. Yes, majority of people are really interested, so great response. Thanks so much for that. So what we'll do is we'll start planning to do some training around the learning management system and get you ready to receive those materials. I think the intro to transition will probably not be on the learning management system because we don't want to overwhelm people with something so big. So that'll be coming a little later in the process. So I think what you'll see is the first few will be delivered to you in an easy method, not going on the learning management system. So our next following question is, how is training done in your organization? And so more specifically, do you do it classroom style? Do you do it webinar? Do you do it online? Do you do it in groups on the unit, kind of like stand-up meetings and that sort of thing? So let's open that poll. So we're looking at these four responses as just a general sense for us so that we kind of can tailor the modules and the education to ways that accommodate you best. Just be another second here. There you go. Lots of classroom training and lots of on the floor in little groups. So great. So let's take a look at number 7, and let's see. Who's doing the training? Who's doing the training in your place? A staff development person? Is it nursing, or is it somebody else altogether? So open that up, and let's see what we've got. Let's take a look. Staff development person, nursing, or other. Alrighty, just another minute. Alright, here we go. I know most of you out there probably are doing the training. That's probably why you're on the call with us, with your teams. So let's just take a look. Oh yeah, there we go. So we have staff development person, lots of nursing, and a few others. Okay, so just to reiterate, a lot of times in our pollination education, what we do is we get lots of people. A real coup in our last round of work. We actually had CNAs who were training other CNAs, and so I'd really encourage you to think about that and see how many people you can get helping to train people and make people aware of transitions of care. What's
Margie,
Margie,
this is Pam. Can you let the audience know when they will be able to receive the booklet that you referred to for preparation?
Sure. It's actually something that we'll be sending out after following the webinar with the presentation and the recording. We'll send out the handbook as well as the QAPI self-assessment.
Great. Any other questions you have, Pam?
Not at the moment.
Great, thank you. So, looking at what's next, so what we encourage you to do is take the month, March 26th to April 26th, to begin to prepare your organization for change. Consider all the ways that you can reach others to promote the work. Get together a little team of folks, some of those energizers, and see what you can do to make this an exciting journey for people. Use the guide that you'll receive to help with your planning, and it will give you some general sense of what next steps. It reminds you of some of the things you've heard on the call today. Be sure to complete the Survey Monkey to signal that you're ready to begin, and then you'll begin to receive messages telling you how to proceed once we get that Survey Monkey. Once you fill that out, so we'll be sending you a link to that. So keep an eye out for that. lots of great stuff that we have in store for you, and more than anything, I just want to reiterate from all of the team how delighted we are that so many of you have decided to join us, and I know that'll make a huge difference. So be sure to be capturing those precious moments all along the way, and don't be afraid to share with us, because all of the sharing makes such a difference. It really does, and we have great experience in this area. So share shamelessly. Melissa, I'm going to hand it over to you.
All right, great. Thank you, Margie. So at this time, we'll begin to address your questions. Alicia, can you tell our participants how to get into the queue to ask a question?
Yes, ma'am. If you would like to ask a question, please signal by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure that your mute function is turned off to allow your signal to reach our equipment. A voice prompt on your phone line will indicate when your line is open. Please state your name before posing your question. Again, that's *1.
Right, and you can also submit questions using the chat panel to the right of your screen. Okay? So, do we have any questions in the queue?
We have no questions on the phone queue.
Pam, are there any questions in the chat?
There was an earlier question regarding the national average data that Blake was presenting. Wanted to know what is the latest national average available to all of us. I believe it's Q3 of 2014, but if Blake is available to answer that.
Yes, Pam, that's correct. It's Q3 2014.
And the delay is because all of that data has to come to us through CMS. Is that right, Blake?
That's part of it, and with claims data, there's a back and forth process between the providers and CMS, and so it goes through some adjudication that causes part of the delay as well.
Okay, thank you. And how frequently will that data be provided?
We get data quarterly.
And we will be providing it to the nursing homes on a quarterly basis then. Someone asked a question about the slide presentation. Will it be available? And I believe the answer is we will be making the slides available. Melissa, can you comment on that?
Sure. So within a couple of days, once we have the full recording of the webinar, you'll receive an email that has the recording along with the slide presentation, the handbook guide that Margie spoke about, and a link to the QAPI self-assessment.
Okay. And I have a couple more questions in chat. The question is, if a resident is transferred from one SNF to another, how is readmission allocated?
The readmission itself is looking just at residents that go back to the hospital.
Okay. And another question we have is, how do you receive the hospital readmission data?
I'm sorry, can you ask me that again?
The question is, how do you receive the hospital readmission data?
Okay, so the data that we get from CMS is the Medicare claims data, and that's data that we receive quarterly, and that's how we calculate the hospital readmissions.
Okay. And when will facilities receive their community 30-day report?
So that will, if you need more information, to reach out to your state lead and check to see if we have a community coalition in that area for your facility, and we'll apply those reports to you. Okay,
that's good. To get a hold of the state lead, and the list of names has been on the chat. If the resident, there's another question. If the resident was transferred to another skilled nursing facility within 30 days from readmission and then readmitted to a hospital, how is that readmission allocated?
That's a good question. There's an index admission, and then it goes to the SNF. So if it goes from one SNF to the next SNF, that readmission would probably fall on the second semester.
Okay. Another question is the readmission data on your report the same as the readmission data on the long-term care trend tracker?
No, it's not. This is Medicare fee-for-service claims only, and it's not risk-adjusted. Trend tracker risk-adjusted data.
Okay, thank you. And another question, what does the plan for this coming month need to include? Margie, I believe that would be the...
I'm going to put the slide back go back a few more. Margie, you can take the answer to that question. I'm just going to pull up the slide here that says make a plan for rolling out your educational program.
Yeah, can I get that question one more time? I just didn't quite catch it.
I believe that it was worded, what does the plan for this coming month need to include?
Oh, great. Okay, so on page 11 of the booklet, you can see it has very specific type things. It generally gives you an idea of the actual, put together a little timeline, how you're going to roll it out, to different floors, and an array of different, just organizing principles to help you get started.
Okay. There's another question. Where did we get the booklet?
That's going to be sent out?
It will be sent out to each nursing home. And that booklet is the document that we've made on Series 1, how to prepare for the collaborative. There's a checklist included, preparing your team, sort of giving you the big picture of the collaborative.
That's right.
Okay. And the readmission data that, there's a question, where does each facility get their readmission data that Blake has?
Yep, so if you reach out to your state lead and we can check to see if we have a community coalition in your area, and then we can provide that report to you.
Okay. Again, the care transition leads will get the 30-day report out to their participating facilities, and if anyone else needs it, they can get in touch with their nursing home task lead. There's another question. Do we need to complete the QAPI prior to having the booklet sent? I believe that refers to the assessment QA. Go ahead.
Yeah, so we would like you to have the QAPI self-assessment completed within the next month. That's part of the next steps. Once we have, you have your team, you review the handbook, you complete the QAPI self-assessment and create a plan, then you'll be receiving the first learning module. If you've completed a QAPI self-assessment within the last few months, you can use that information as well.
All right, there's another question. Will the booklet be coming via email or mail?
It will be coming via email as a link to the website where the presentation and the recording are as well. So our emails are coming two ways. You should look for emails from the New England QIN-QIO, so that's NEQIN-QIO. And we've also, just to reinforce that, to make sure you receive the information, the state leads are sending information as well. It may seem like email overload right now, but until your email or the folks on the call are become more familiar with the emails as they're coming through, we're hoping that we can cut back on that. And also, sometimes the emails are going into your spam, so we just want to make sure you're receiving it.
Somebody has asked, could we summarize the answers to these questions and distribute, because sometimes it is difficult to hear the answer.
Yes, we can do that.
Are there any other questions coming up in chat? I don't see any others right now.
Alicia, are there any people on the queue?
Yes, ma'am. We'll take our first question.
Hi, maybe I missed the answer to this question, but the reimbursement based on quality scores, how we perform as a facility, will that be based on the composite score as a whole, or will that be based on individual questions? And if it is based on the individual performance questions that we score at, how is that weighted? Thank you.
So that program is still in development, and not all of the details are 100% clear right now. Where I do recommend you go for more information is cms.gov, and then you can click on the Nursing Home Quality Initiative. There is a link there to a report that CMS has made to Congress regarding the value-based purchasing SNF program. As that report stands right now, it recommends making the value-based purchasing scores linked to currently available quality measures, things like your MDS quality measures, staffing reports, health inspections, and state survey results, which will result in a score. So there's more information about that in that report.
We'll take our next question.
Hi. Could you go over how we actually define the composite score? I'm seeing different numerators and denominators, so it's changing every month. Is that based on what we're submitting for MDSs only?
Yeah, so the data for the composite score is provided to us monthly. And so when you look at data like this and compare it to your own data, there's potential that it may not match up, because when you pull the data, say 2-3 months out, there's still chances that your MDS data might change. So you may not see exact matches to your own data. As far as the composite score, it's just a sum of the numerators and denominators across all the long stay measures. And as we said, that this measure is an evaluation measure for the QIOs. It's not an evaluation measure that the nursing homes have. So I just want to make that part clear.
Okay.
Are there any other questions in the queue?
No further questions.
Okay. So thank you all for these great questions. I just want to make a few last announcements before we end today's webinar. So just to reiterate the next steps, you will receive an email with a link to a very brief evaluation about today. We ask that you do complete it, because your feedback can help us only improve these webinars. And it's our goal to provide you with meaningful programs. Within the next few business days, you will receive another email that contains a link to today's presentation, as well as a recording, a QAPI self-assessment, and the collaborative handbook. Again, please note that you'll be receiving emails from the QIN-QIO, as well as your state leads, to ensure that the information is reached successfully. And that's all I have. We are ending a few minutes early, so we're happy to give you about 25 minutes back in your day. And thank you for joining us. Have a good day.
That concludes today's conference. We thank you for your participation.